Hello everyone, I'm Dr. Sandeep Sharma and I welcome you to this part 4 revision session of medicine for FMGE exam. The system I'm going to take up is pulmonology. As is the routine, I will be giving a few disclaimers that this revision session is not a replacement for your existing notes. I hope all of you are preparing well. And some of you asked me, sir, why are you not taking a live session? It is deliberate. Live session. I've taken a lot of live sessions in the past for pediatrics, my original subject, but I'm not taking is number one because the exams are very close. There are always some connectivity issues even if you are taking from a studio. Secondly, in a live session, there is a lot of time wastage. Uh, Thirdly, not all people are able to join at the same time, and so what happens is you are like, okay, the session is there, I will see later. And many times the discussions go in a totally different direction. कभी कभी बात निकलती है तो दूर तलक जाती है, and we don't want any time to be wasted, right? So that is why it's a recorded session I'm sharing here. After you crack your exam, I hope all FMG students who are listening to this, you crack your exam, you will crack your exam, and once the results come and later on we connect for NEET PG or next, then we will take a live session, right? So let us now focus on the topic that we are going to take up. It's an integrated topic. Pulmonology is not in isolation. So second part of this video, I will be talking about case scenarios and one-liners. Initially, I will be talking about some topics, the understanding of which is relevant. So first of all, we have the lung volumes and capacities. Top questions from this are asked in the paper A as well as paper B. So lung volumes, what they are, the normal values, they are asked in paper A in the physiology part. Applied portions are asked in paper B. So let us first start with the lung volume. So this is the flow chart. This is the depiction of a spirometric test which has been done, and various types of volumes and capacities have been shown. I hope you know that volume is a single value and capacity is usually a culmination or combination of multiple things, right? So let us try to break down and revise all the key definitions here. So first of all, we have the tidal volume. What is tidal volume? When we normally breathe, the volume of gas which moves in and moves out, that is called as tidal volume. You can see in the picture, this is tidal volume. Usually the tidal volume is somewhere in the range of 500 ml. These normal values I will be summarizing in the end, right? Then second definition is inspiratory reserve volume. Inspiratory reserve volume is maximum volume of gas which is inspired from the end tidal inspiration. So what additional air you can inspirate apart from tidal volume, that is called as inspiratory reserve volume, right? Tidal volume ke baad whatever maximum you can inspire, that is called as inspiratory reserve volume. Then the third definition is a capacity. So it will be a combination of two things. So inspiratory capacity is maximum volume of gas inspired after a normal expiration or a resting expiration. So inspiratory capacity is a combination of tidal volume along with IRV. तो एक पर्सन ने जब नॉर्मल एक्सपिरेशन कर दिया, आफ्टर दैट द मैक्सिमम वॉल्यूम विच कैन बी टेकन इन, दैट इज कॉल्ड एज इंस्पिरेटरी कैपेसिटी. एंड रिमेंबर दिस पॉइंट दैट इट इज अ combination of tidal volume along with inspiratory reserve volume. This has been asked in the past in the FMG exam. I will show you the question also. Then we have expiratory reserve volume, which is the maximum volume of gas expired after a normal from the resting expiratory level, right? तो एक्सपिरेशन खत्म हो गया, उसके बाद जो मैक्सिमम गैस विच कैन बी एक्सपायर्ड, इट इज द एक्सपिरेटरी रिजर्व वॉल्यूम. Then we have vital capacity. Vital capacity refers to maximum volume of gas expired after a maximal inspiration. तो इसमें क्या आ जाएगा? इसमें दोनों आ जाएगा, inspiratory capacity and expiratory reserve volume. तो दोनों maximum inspiration, maximum expiration, they combine together is called as the vital capacity. Then we have residual volume. After you have expired maximally, उसके बाद भी lungs collapse नहीं होते, the airways do not collapse, there is still some air left in the lung. The amount of air which is always there and which cannot be taken out, that is called as residual volume. जो बच गया lungs में, पूरा कोशिश लगा लिया, उसके बाद जो बच गया, that is residual volume. In this video, I will try to strike a balance between English and Hindi as some of you suggested. So don't worry, I'll not compromise on the content as well as the understanding part. So what is residual volume? After you have maximally expired, still there will be some volume of air remaining in the lungs, in the airway, that is called as residual volume. And then we have total lung capacity. What is total lung capacity? Total lung capacity is about 6 liter. It combines everything. So volume of gas in the lungs at the end of a maximum inspiration is called as total lung capacity. And then we have RV by TLC, it is a ratio which is sometimes used in the books, so you can just remember it's a ratio. And finally, we have functional residual capacity, which is the volume in lungs at resting expiratory level. It involves a combination of ERV along with RV, right? तो इसको याद करना है, and just I am giving it at one place so that you can listen to the video again, and the PDF which you will be getting, see the PDF, listen to what I'm saying, and just correlate and add them to your notes. What are the normal values that you need to remember? Some normal values you need to know. They are sometimes can be asked in the exam. Recently नहीं पूछा गया, but they can be asked anytime in your paper. So what is the normal tidal volume? The normal tidal volume in you and me, it is about 500 ml. छोटा बच्चा होगा in a pediatric child, it will be totally different. Then what is the inspiratory reserve volume जो हमने बात किया? Maximum volume of gas after end tidal inspiration, that will be about 3300 ml. 3300 ml. उसके बाद आता है अपना कौन सा लिखा हमने? इंस्पिरेटरी कैपेसिटी. सो इंस्पिरेटरी कैपेसिटी इज ए कॉम्बिनेशन ऑफ VT प्लस IRB. तो 3300 प्लस 500 कितना हो जाएगा? दैट विल बी 3800 ml. इंस्पिरेटरी कैपेसिटी. अगला क्या है? ERB, expiratory reserve volume. So expiratory reserve volume in the patient is, you can remember a single value, it is 1000 ml. And then we have vital capacity, VC, which is a combination of IC plus ERV. तो ये total कितना हो जाएगा? It will be about 4800 ml because it's a combination of IC plus ERV. Then we have residual volume, amount which remains in the lungs which cannot be taken out, that is 1200 ml. Then we have total lung capacity. Now total lung capacity जो होता है TLC, remember that TLC is a combination of all the volumes that we have read. So TV plus residual volume plus IRV plus ERV, ये सारा combine करते हैं, तो that is called as the total lung capacity, as you can see in the image also, and it is about 6000 ml. टोटल करेंगे तो ये 6000 ml आएगा, about 6 liter. But it varies from person to person, and in very obese people and sometimes in those with some underlying disease or with a sedentary lifestyle or with increasing age, you find that it can dip to as low as 4.8 liter also. But ये 4.8 to 6.5 के बीच में रहता है, and average value in a healthy adult that we take is 6 liter, that is 6000 ml. फिर आपसे पूछ सकते हैं RV by TLC रेशियो नॉर्मली कितना होता है? तो RV by TLC रेशियो नॉर्मली इन परसेंटेज हम निकालते हैं तो इट इज अबाउट 20% इन नॉर्मल इंडिविजुअल. हर आदमी में नॉर्मल इतना होता है. एंड व्हाट इज द फंक्शनल रेसिडुअल कैपेसिटी? FRC, फंक्शनल रेसिडुअल कैपेसिटी इज अ कॉम्बिनेशन ऑफ ERV प्लस रेसिडुअल वॉल्यूम. तो ये आपका आता है टोटल 2200 ml इफ यू कंबाइन देम, right? So these are some of the normal values that you need to know. Apart from this, if you look at past papers in physiology, there is a old question where they have asked you what is minute volume. अगर और इसके ऊपर न्यूमेरिकल क्वेश्चन आया था. So what is minute volume? Minute volume is also written as respiratory minute volume. Minute volume का definition is tidal volume multiplied by respiratory rate, right? तो जो भी टाइडल वॉल्यूम क्वेश्चन में दिया होगा, अगर नहीं दिया तो 500 लेंगे, एंड रेस्पिरेटरी रेट दे विल मेंशन इन द क्वेश्चन, एंड दैट विल बी योर आंसर. सो दैट विल बी द मिनट वॉल्यूम इन द पेशेंट. तो इसको याद कर लो, इसको कहीं पर लिख लो. लास्ट मिनट रिवीजन के लिए देयर इज अ ओल्ड MCQ पॉइंट ऑन दिस, राइट? सो दिस इज द फर्स्ट थिंग. अब मैं इनकी डिटेल में नहीं जा रहा हूं बिकॉज एज आई सेड बिफोर, दिस इज अ integrated class and it's a revision class. 2 weeks left before the exam, but this is a summary of what you need to revise in this topic, because applied part of this can be asked to you in the exam in the paper B as well. Moving further, let us talk about obstructive versus restrictive lung diseases. Now there are many ways of classifying the pulmonary disorder, but the easiest way and the best way is to divide them into two categories, obstructive and restrictive. Restrictive के आगे further subtypes होते हैं, obstructive has its own further subtypes. So how do we distinguish between them? देखो, let us make a table here. तो एक तरफ हमारा होगा obstructive disease, दूसरी तरफ we have restrictive disease, right? So सबसे पहले what is the basic problem? Obstructive में प्रॉब्लम आती है फ्लो के अंदर, सो इट इज कंसिडर्ड टू बी अ फ्लो प्रॉब्लम. रिस्ट्रिक्टिव के अंदर प्रॉब्लम आती है वॉल्यूम के अंदर. एग्जांपल देता हूं, ऑब्स्ट्रक्टिव डिजीज लाइक आस्मा, ऑब्स्ट्रक्टिव डिजीज लाइक एम्फाइसीमा, ऑब्स्ट्रक्टिव डिजीज लाइक ब्रोंकाइटिस. इन पेशेंट्स के अंदर ऑब्स्ट्रक्शन की वजह से फ्लो नहीं हो पाता, एंड फ्लो इज मैक्सिमली अफेक्टेड इन एक्सपीरेशन. तो सांस, द एयर कैन मूव इनसाइड बट एयर कैन नॉट फ्लो आउटसाइड. So there is air trapping in the patient, and so it is considered to be a flow problem. What is restrictive lung disease? Typical example, interstitial pulmonary fibrosis. If fibrosis has happened, alveoli cannot expand. The airways cannot expand, lungs cannot expand, and so volume of the lung will decrease. Flow is not a problem, volume of the alveoli, volume of the lungs is a problem, and so it is considered to be a volume problem. So before I show you the images and the key points, you should understand कि obstructive के अंदर क्या है? There is obstruction. This obstruction is causing decreased flow. Flow is decreased maximally during expiration, and so obstructive have air trapping. On the other hand, restrictive diseases, flow is normal, but the alveoli cannot expand, right? Obstructive के अंदर क्या था? Airway में problem थी. और restrictive के अंदर क्या है? Between the alveoli or maybe in the chest wall you have problem, and so there is a decreased volume of the respiratory area, and that is causing a volume problem. Let us discuss the examples. So obstructive के अंदर, as I said, they can't expire fully. Expiratory flow is reduced, leading to air trapping in the patient. In restrictive, there is an inability of alveoli to expand fully, and so there is reduced air entry in the lungs. What are the examples? Obstructive के examples are typically COPD, chronic obstructive pulmonary disease. COPD has two subtypes, you know, emphysema as well as chronic bronchitis. Then we have asthma. We have bronchiolitis, also called as acute bronchiolitis, more common in children, can occur in adults, and bronchiectasis is also categorized as obstructive. Bronchiectasis को लेके अलग-अलग guidebooks have different values. Some of the internet sources say bronchiectasis can be both obstructive, restrictive. Absolutely wrong. Harrison very clearly says bronchiectasis is an obstructive problem. I know this. People who read Harrison know this, and obviously the examiners also know this, that this incorrect information is there on many social media platforms. And so tomorrow if you get a question on this and they ask you bronchiectasis obstructive है या restrictive है, safely mark obstructive, clearly mentioned in Harrison. Harrison एक textbook है, उसमें अगर medicine में कुछ भी लिख दिया, that is a final word, right? Remember that. Coming to restrictive, as I said, restrictive can be of three sub-varieties. You can have parenchymal causes where there is a problem in the lung parenchyma, which includes idiopathic pulmonary fibrosis. There is also a pneumonia-like condition called as DIP, but I'm not going into the detail because that is rare. Then we have asbestosis and sarcoidosis. Then we have second category in restrictive called as neuromuscular weakness. It includes Guillain-Barré syndrome, myasthenia gravis, and amyotrophic lateral sclerosis. Full form आपको पता है already. Amyotrophic lateral sclerosis is a life-threatening condition, and many celebrities and many film actors in particularly Western world have also died because of ALS. And C is chest wall. Chest wall involvement can restrict the air entry. It can restrict the volume in the patient, producing a lung disease. It typically includes kyphoscoliosis and ankylosing spondylitis. And suppose you have an obstructive patient and you have a restrictive patient, what advice you are going to give? So in case of obstructive lung disease, हम पेशेंट को अपार्ट फ्रॉम थेरेपी हम क्या एडवाइस करते हैं? व्हेनेवर यू हैव अ एक्सैसरबेशन, व्हेनेवर यू हैव अ वर्सनिंग, स्लोली ब्रीथ करना है बट डीपली ब्रीथ करना है. सो इफ यू ब्रीथ स्लोली एंड एक्सपायर स्लोली, this is going to be helpful in obstructive lung disease. Restrictive lung disease, we advise breathe fast but breathe shallow in the patient in case they find some acute worsening happening. This is a very, very important thing. It is not mentioned in many of the FMG material, but you would be surprised to know there is a past question on this in one of the Central Institute PG entrance exam, right? 4-5 years back, it had been asked there. So MCQ is an MCQ, and because we are discussing the topic, so you need to remember it, right? ये clinical adaptation है जो हम advise करते हैं. This is something we advise to the patient in case you have you're out somewhere and you have a worsening. What kind of breathing you should do to calm yourself down and before you get medical attention? It's they are adult patients, right? So what you will advise? Obstructive में slow but deep breathing, restrictive में fast but shallow breathing is advised apart from the medical management. Now, if you do spirometry, how you are going to distinguish between obstructive and restrictive? Now, these are the values on which a lot of questions have been asked, so you need to remember them. सबसे पहले भी check करते हैं FE1. FE1 refers to forced expiratory volume in the first second. In obstructive, it is decreased. Restrictive lung disease, it is normal to decreased. Then we have forced vital capacity, FVC. In obstructive, it is normal to slightly decreased. Restrictive also, it is decreased. Then we have the FEV1 over FVC ratio, very, very important. Please mark it. It's very often asked in the exam. Already 4 years back, it was asked in one of the PG entrance exam also. So FEV1 by FVC ratio, obstructive may it is reduced, restrictive it is normal to increase. What is the normal FEV1 by FVC ratio? It is normal is 0.8. तो ऑब्स्ट्रक्टिव में ये हो जाता है लेस देन 0.8 एंड रिस्ट्रिक्टिव में इट इज आइदर 0.8 और मोर देन 0.8. सो 0.8 नॉर्मल है तो हम कहते हैं नॉर्मल और increase than normal. So FEV1 by FVC ratio is a very important clue to distinguish between obstructive versus restrictive lung disease. Then we have FEF 25 to 75, which is decreased in obstructive lung disease but normal in restrictive lung disease. Then we have residual volume. As I said, air trapping is happening. तो air trapping किसमें हो रहा है? Obstructive में, तो residual volume बढ़ जाएगा because trapping is happening. Restrictive में volume problem है, तो residual volume is always going to decrease in the patient. Then we talk about the total lung capacity. Put a Q on top of this. Total lung capacity, already an MCQ. Total lung capacity is normal to increase in obstructive, but it is reduced in patients with restrictive lung disease. Then we have DLCO, diffusion capacity of lung for carbon monoxide. It's very, very important and can be asked as a fresh question. Obstructive और restrictive में difference क्या होता है? In restrictive, it is always decreased. तो कार्बन मोनोऑक्साइड जो डिफ्यूजन कैपेसिटी है दैट इज ऑलवेज रिड्यूस्ड बिकॉज ऑफ फाइब्रोसिस और डिक्रीज चेस्ट वॉल मूवमेंट. इन ऑब्स्ट्रक्टिव लंग डिजीज it is normal to slightly increased in asthma, but it is reduced in emphysema. What is happening in emphysema is, I hope you know, because of smoking or because of metabolic disorders like alpha-1 antitrypsin deficiency and similar disorders, there is a loss of septa and there is a dilatation and loss of gas exchange area. And whenever there will be a reduced gas exchange in the patient, that will cause reduced DLCO in the patient. Restrictive में भी diffusion में problem है and emphysema में भी it is the problem. So both emphysema despite being obstructive lung disease, it has reduced DLCO. Restrictive has reduced DLCO. Asthma has normal to increased. It varies from person to person, right? Now, the third tricky thing we are going to discuss here is, तो पहला हमने पढ़ा about the capacities and lung volumes. Second, we talked about obstructive versus restrictive, the clinical aspect and the spirometric value. Third thing on which question has been asked, visual question has been asked in FMG exam paper B medicine, flow volume curves. This is how a normal flow volume curve looks like. Flow volume curve को volume loop भी कहते हैं, volume curve भी कहते हैं. So what do you need to understand here? First of all, if you get this photograph, you first need to break down what is the meaning of this. देखो ये this is on the x-axis you have the volume which is mentioned. On the y-axis you have flow of the patient. We make the patient perform spirometric maneuver and then we check how much is the flow, how much is the volume. Start कहाँ करते हैं? Start करते हैं from this point. This is, I am labeling it here. This is called as the starting point. This is where you start. हम पेशेंट को कहते हैं इंस्पायर करो. When he inspires, the entire lower part, ये सारा जो नेगेटिव वाला है, this entire part is called as the inspiratory part. Now you will ask कि सर ये बॉटम पे क्यों है? Because inspiratory part is negative. I hope you know कि pressure inside the thoracic cavity is negative, and when we inspire, thorax expands and it becomes more negative. तो इंस्पिरेशन में फ्लो क्या होगा? नेगेटिव होगा, राइट? इट इज गोइंग इनसाइड, सो इंस्पिरेटरी फ्लो इज नेगेटिव. तो ये जो एंटायर बॉटम वाला कर्व है, द स्मूथ कर्व विच इज कन्वेक्स इन नेचर एंड विच इज वेरी रेगुलर काइंड ऑफ कर्व, दैट इज इंस्पिरेटरी कर्व, राइट? मैक्सिमम इंस्पिरेशन जब कर लेते हैं, रेसिडुअल वॉल्यूम भी है, वो सारी वॉल्यूम भी है, तो ये जो पॉइंट आता है, देखो यहां से ब्रीथ करना स्टार्ट किया, देन फ्लो बढ़ा, फ्लो मैक्सिमम हुआ, यहां पर मैक्सिमम होने के बाद द फ्लो ऑफ द पेशेंट स्टार्ट्स फॉलिंग because you can't keep on inspiring. एक पॉइंट आएगा जहां पर इंस्पिरेटरी फ्लो बंद हो जाएगा, वो वापस बेसलाइन पे आ जाएगा. दिस इज द पॉइंट वेयर टोटल लंग कैपेसिटी इज अटेन्ड. तो ये स्टार्ट कहां से होता है? रेसिडुअल वॉल्यूम से स्टार्ट होता है एंड एंड्स एट टोटल लंग कैपेसिटी. नाउ फ्रॉम टीएलसी ये सारा पॉजिटिव, दिस एंटायर पॉजिटिव ग्राफ इज कॉल्ड एज द एक्सपिरेटरी ग्राफ. दिस इज द नॉर्मल एक्सपिरेटरी ग्राफ, राइट? इसमें इनिशियली तो पेशेंट फोर्सफुली एक्सपायर करता है, एंड देन एक पीक एक्सपिरेटरी फ्लो आने के बाद ग्रेजुअली ये घटना शुरू होता है, एंड दिस फ्लो विच हैपेंस आफ्टर पीक एक्सपिरेटरी फ्लो इज यूजुअली लीनियर इन नेचर, right? It is usually linear in nature because after a peak expiration, whatever outflow has to happens because of the recoil processes and it is not under voluntary control. तो ये ऐसा जो कर्व मिले आपको, ऐसा एक फोटो हो and you have the curve looking something like this. The upper curve is something like this and the lower curve is convex like this. इसे कहते हैं normal flow curve. This upper part is the expiratory part, this lower part is the inspiratory part. कहां से and what is the flow which happens? This is the flow which happens, and this कहां से start होता है? It starts from the residual volume, और इंस्पिरेशन कहां खत्म होती है? दैट पॉइंट इज कंसिडर्ड टू बी टोटल लंग कैपेसिटी. अगर ये कॉम्प्लिकेटेड नहीं पढ़ना तो वट एवर आई मेड जस्ट हियर, दिस इज ऑल यू नीड टू अंडरस्टैंड, राइट? पहला समझ आएगा तभी वी विल बी एबल टू आइडेंटिफाई दी पैथोलॉजिकल प्रोसेसेस. Personally, I like teaching normal flow volume curve. Even in my PG, I used to teach my juniors about it. Now I teach in my super specialty thing. कल को नीट बीजी का बात करेंगे, then we will discuss about the details. Right now it's a revision class, so I'm not going into unnecessary detail. Right? तो अभी एग्जाम में क्या पूछेंगे? एग्जाम में they give you a case scenario or they simply give you a photograph and ask you what is the likely diagnosis. So I hope you will not go wrong in a normal flow volume curve. This is how a normal flow volume curve looks like, right? Normal flow volume curve looks something like this. इस shape को याद कर लो. Then we have the abnormal flow volume curve. तो पहला abnormal flow volume curve that you need to know is a superposition of multiple things. आपको एग्जाम में पूछ सकते हैं ऑब्स्ट्रक्टिव डिजीज है या रिस्ट्रिक्टिव डिजीज है, तो कैसे पता चलेगा? देखो, दिस ब्लैक वन इज द नॉर्मल फ्लो वॉल्यूम कर्व, राइट? हम एक्सपिरेटरी कर्व को देखते हैं. एक्सपिरेटरी कर्व इज एक्चुअली मोर सेंसिटिव टू डिस्टिंग्विश बिटवीन रिस्ट्रिक्टिव वर्सेस ऑब्स्ट्रक्टिव डिजीजेस. बाकियों पे भी we will go, but first try to understand. 3 diseases have been shown here. First of all, look at the blue curve. Blue curve जो है ये है obstructive lung disease. Obstructive lung disease में क्या होता है? Can you see कि total lung capacity जो है ये further left को shift हो गया है. Left को shift होने का मतलब होता है, if you see here, it is actually total lung capacity is, ये सारा values जैसे हम इधर को जाते हैं तो values decrease. The values tend to decrease. तो total lung capacity is increased in obstructive lung disease. तो इस पेशेंट में क्या होगा? There will be a shift to left. So remember, obstructive lung diseases के अंदर जो expiratory column है, expiratory part, इसके 2 चीजें होती हैं जो आपने देखनी है. Expiratory part first of all shifts to left. Shifts to left. Can you see? ये left को shift हो गया. Secondly, the expiratory part, इसका जो straight line था, that becomes concave. So concavity is produced after peak expiration. तो जो straight line थी वो अगर concave हो जाए, convex से या straight line से it has become concave, तो उसको कहते हैं obstructive वाला. तो ये इसको obstructive वाले को कैसे define करते हैं? It is shown something like this. नीचे वाला कर्व ऐसा रहेगा, but upper curve will be something like this. तो ये concavity produce हो गया and it has shifted to the left side. Sometimes they will not give you a normal curve to compare it with it, right? तो बस इतना फोटो दे देंगे, तो इतना फोटो दे देंगे तो हमें क्या बताएगा कि this is obstructive lung disease? हमारा concavity बताएगा. So remember, this is how obstructive lung disease flow chart will look like. On the other hand, restrictive lung disease, I told you it can be of multiple type. उसको 2 पार्ट में डिवाइड कर देते हैं. Restrictive, which is parenchymal, that is fibrosis, and restrictive, which is extra parenchymal, which includes the chest wall changes, etc., obesity, ankylosing spondylitis, kyphoscoliosis, etc. जो आपका restrictive parenchymal है, remember this funda, restrictive parenchymal lung disease, this will look similar to the normal flow curve, but there will be shift to left, shift to right. Shift to right. Shift to right का मतलब जो total lung capacity है that will fall. TLC tends to fall in the patient, right? तो can you see here this brown colored thing? So this is restrictive lung disease का brown वाला pattern which is shifting to the right, and इसका जो total area है वो भी कम हो गया. It has become narrow. This also becomes narrow because total lung capacity volume जो है कम हो रहा है. So if it becomes narrow and shifts to the right, that is restrictive lung disease, parenchymal in nature. और तीसरा होता है restrictive lung disease एक्स्ट्रा पेरेन्काइमल, रिस्ट्रिक्टिव लंग डिजीज एक्स्ट्रा पेरेन्काइमल। इन पेशेंट्स के अंदर रहेगा वही, सुपर इंपोजिशन होगा, देयर विल बी सुपर इंपोजिशन, बट द ग्राफ साइज will be reduced. Can you see this red color curve? If you see, वो curve जैसा वैसा ही है, but उसका एरिया कम हो गया है. So this is restrictive extra parenchymal as shown by the red one. तो ये तीन फोटोज याद कर लो, तीन फंडा याद कर लो. Examiner is not going to give you a very tough flow volume curve. Trust me, in real life flow volume curve इतना सिंपल नहीं होता है. They are actually more complex than this. But here the examiner is interested in knowing, before you get your degree, can you make out the simple flow curves tomorrow in internship or not? And तो ज्यादा पूछे जाने के chances क्या हैं? Obstructive, restrictive parenchymal, restrictive extra parenchymal, and these three will tell you how it is going to be, right? There are some other flow curves that you need to know additionally. Let us now have a look at these abnormal flow volume curves or loops, which you need to remember. They can be as complex as you want them to be, but I will try to just explain the key things so that you don't go wrong in the paper. So look at this first curve. ऐसा curve देंगे और बोलेंगे tell the likely diagnosis. Now in this curve, if you see, ये जो blue वाला limb है, this blue limb is a normal curve. ये एक normal है, right? And this maroon colored or red colored curve is the patient. तो आप फर्स्ट फोटो में देखो, ऐसा इमेज आया है, तो पेशेंट को देखो एंड टेल द लाइकली डायग्नोसिस. नाउ व्हाट यू कैन सी इन दिस पेशेंट इज दैट इंस्पिरेटरी एंड एक्सपिरेटरी लिम्स आर फ्लैटेंड, राइट? अपर वाला एक्सपिरेटरी है, लोअर वाला इंस्पिरेटरी है, बोथ आर फ्लैटेंड एंड बोथ आर फ्लैटेंड सिमेट्रिकली. इफ यू फाइंड दैट इन अ फ्लो वॉल्यूम कर्व, इंस्पिरेटरी ग्राफ, इंस्पिरेटरी कर्व as well as expiratory curve, both of them flatten symmetrically. ऐसा फोटो याद कर लो. You have to imprint this photograph in your mind. So this indicates likely fixed upper airway obstruction. Fixed upper airway obstruction. Fixed airway obstruction में क्या होगा? There will be both inspiration as well as expiration getting affected. So fixed upper airway obstruction should be suspected. For example, ENT tumors involving the upper airway. So any tumors in the upper airway, larynx or trachea in upper airway, that will produce a obstruction like this. Another example is tracheal stenosis. What is tracheal stenosis? Narrowing of the trachea, many times due to inflammation, infection, sometimes due to congenital problems, sometimes due to prolonged intubation. There will be narrowing occurring in the trachea and that can produce a fixed upper airway obstruction. So when you do flow curve, तो ऐसा flow curve आपको मिलेगा. Second type of flow curve will be something like this. Now if you see, look at this patient. As I told you, the blue one is the normal curve. Look at the patient curve. Patient में आपको दिख रहा है कि expiration is normal in the patient. Expiratory curve is relatively normal, right? It is superimposing with the normal curve. But look at this part. The inspiratory curve is flattened in the patient. So if only inspiratory curve is flattened, only inspiratory curve is flattened, that indicates there is a variable or airway obstruction. फंडा क्या है यहाँ पे? When both inspiratory and expiratory are affected, वो fixed होता है. When one of them is affected, इस तरह के curve में, then it is variable. और उसके अंदर you have to see कि which is getting affected. So इसको, because inspiratory is getting affected, so this is variable extrathoracic. Variable extrathoracic upper airway obstruction. Variable extrathoracic upper airway obstruction. Right? And look at the third curve. Third curve के अंदर उल्टा हो गया. As you can see, the expiratory curve is flattened, whereas the inspiratory curve is relatively normal. So here only the expiratory part is flattened. Expiratory curve is flattened. And so this will indicate, अगर दोनों में से एक affect हो रहा है तो variable कहते हैं, right? Variable upper airway. But इसमें क्या है? Variable intrathoracic, inside the thoracic cavity, upper airway obstruction. They will not ask you the fine details कि इनके causes बताओ. That will make it too complicated. But just to be safe, to be on the safer side, as a part of revision, remember कि ये flow curves भी आपको पूछे जा सकते हैं. These can be asked to you in the exam, right? And one flow chart also you need to have a look at it. Look at this flow chart. Can you see एक circle की तरह बन गया है? This is the patient's curve. ये patient का curve है, and this blue one is the normal one. So this, what is this type of flow curve indicating? I told you, जब inspiratory expiratory दोनों affect हो रहे हैं and the overall उसका volume affect हो रहा है and it is getting flattened symmetrically, but not in the form of a plateau kind of thing. Plateau kind of thing होगा तो airway obstruction होगा. If you find a circle getting produced inside the normal flow curve, तो इस सर्कल लाइक प्रोजेक्शन अगर आपको मिले तो दिस इंडिकेट्स रिस्ट्रिक्टिव लंग डिजीज, बट ड्यू टू अ पर्टिकुलर प्रॉब्लम, नॉट ड्यू टू फाइब्रोसिस पैरेनकाइमल, नहीं, रिस्ट्रिक्टिव लंग डिजीज ड्यू टू न्यूरोमस्कुलर वीकनेस. एंड दिस टाइप ऑफ ग्राफ विल बी सीन इन पेशेंट्स विद मायस्थीनिया ग्रेविस. तो ऐसा सर्कल की तरह मिले तो उसको हम we will indicate likely to be myasthenia gravis. Guillain-Barré syndrome can also produce similar curve in the patient, right? तो normal पता लग गया and abnormal पता लग गया, and with the various values, various examples we have discussed. Let us move further and talk about a useful concept here. Now you can get a difficult question based upon this. ये concept समझ आ जाएगा, it will be even more easy for you. Question बोलेगा, look at this first graph. ये पहला वाला graph. This is graph number 1. A patient came to you, adult patient. You did spirometry and this graph was obtained. On giving salbutamol, the graph changed to this. What is the likely diagnosis? तो देखो, we will go systematically here. If you see, ये उन्होंने normal graph भी show किया है. You would see कि ये है normal वाला, ये dotted वाला normal है, right? And this one is the patient graph. Shift to left दिख रहा है? Number 1. Number 2, can you see the concavity getting produced? तो concavity and shift to left किस में दिखता है? Obstructive lung disease. So ये we are dealing with obstructive lung disease. अब obstructive lung disease तो बहुत सारे हैं. Salbutamol देने के बाद the graph became normal. तो ऐसी कौन सी कंडीशन है where obstructive lung disease becomes normal on giving short acting beta agonist? Because it normalized with salbutamol, short acting beta agonist. So the diagnosis in the patient, it is bronchial asthma. It is bronchial asthma. तो बोलेंगे एक ग्राफ था जो नॉर्मलाइज हो गया, फोटो की फॉर्म में आ सकता है. Concavity disappeared after giving salbutamol. What is the likely diagnosis? Asthma. Or they will say, look at the photograph. After giving salbutamol, the initial graph changed into this kind of graph. What is the likely diagnosis? Bronchial asthma. अगर वो ग्राफ चेंज ना हो, it will be some other obstructive lung disease. Most commonly, COPD will be the likely diagnosis. Right? Now let us solve some MCQs. FMGE MCQ, August 2020. 60-year-old male patient complaints of dyspnea on climbing stair. Heart sound, breath sounds are normal. Flow volume loop is shown in the red. तो ये है patient का curve, right? Total overall volume कम हुआ and shift to right हुआ and overall volume has reduced. So this is likely to be restrictive lung disease. And which type of restrictive lung disease? Restrictive parenchymal disease. I told you, extra parenchymal में size कम होगा but shift नहीं आएगा. It will remain within the normal loop. Obstructive में shift to the other side will happen and concavity will be produced, right? Look at the next one. Which of the following is true about functional residual capacity? Options overlapping है. This becomes a difficult question if it comes in paper A or paper B, because आप कितना भी याद करके जाएं, if you have not revised them in last day before the exam, you will forget them. So my advice to you, if you are keeping a diary or a copy, things to revise on the last day, spend 5 minutes in the evening before the exam on capacities and lung volumes and their formulas. You may not get a question, but if you get a question, if you have not revised one day before, there is a possibility you will go wrong. So 4 options दिए हैं, so they will not be giving such easy option. Which of the following is true about functional residual capacity? तो functional word जब आता है तो उसके अंदर it is always after a normal breathing which has happened. You can take the help of this chart also which I discussed with you. If you look at this, functional residual capacity का definition क्या था? Volume in lungs at resting expiration level. Resting expiration level का मतलब forced expiration नहीं, after a normal expiration, whatever remains in the lung. So it includes residual volume with expiratory reserve volume, and so the answer to this question is A. Pause the screen, listen, understand, and then only go forward. Now have a look at this question. Which of the following is true about inspiratory capacity? It looks easy, but it is not easy. And it looks similar to the previous question, but you need to know precisely. Inspiratory capacity क्या होती है? The maximum volume which you can take in, tidal volume and forced volume after that. So that is inspiratory volume, reserve volume apart from that. So TV plus IRV is the definition of inspiratory capacity. Have a look at this table. What is it saying? Inspiratory capacity refers to maximum volume of gas inspired from resting expiratory level. So resting expiration से resting inspiration तक, that will be tidal volume, and then the maximum gas you can take in forcefully, that is inspiratory reserve volume, right? So tidal volume plus volume inspired forcefully, which is nothing but inspiratory reserve volume. So TV plus IRV is inspiratory capacity, and so answer number C is the correct answer here. So option number C. I keep repeating, pause these questions, have a look at them once again in the last week before the exam. They are tricky, but they are rewarding if you get a question on that, right? Ab kya aayega to this to only examiner knows and God knows. And then look at this question, which is not true regarding an obstructive lung disease. All of them are actual questions. You can have a look in your guides also. They are mentioned in the guides also. So which is not true regarding an obstructive lung disease? Now FEV1 reduce ho sakta hai? Yes. FVC can reduce? Yes. Vital capacity can sometimes be low. TLC is increased because of air trapping, I told you. And what is not true in this question? Low TLC. TLC is increased in the patient. TLC is increased in the patient. Low TLC is a feature of restrictive lung disease in the patient. Now let us have a look at some case scenarios here, right? Look at the first case scenario. This MCQ scenario, very similar to this, has been asked in INI-CET exam and of course in FMG exam. That is why we are discussing here. So the question will say, either there is a asthmatic patient or a cystic fibrosis patient. Something which is common in asthma or in cystic fibrosis. Secondly, they will say the patient is having productive cough. Productive ka matlab, the patient is having more mucus production. What kind of mucus? Identify the keyword brown colored sputum. Thick plug hai, thick mucus hai, and it is forming mucus plugs. Something which is coming out in the form of brown mucus plugs. Third thing, there is dyspnea, difficulty in breathing, and raised immunoglobulin E. I hope you understand the funda that immunoglobulin E is elevated in allergic disorder. तो patient है कोई asthma या cystic fibrosis का who's having a productive brown colored cough और उसमें allergy tendency है. So allergy to what? It is allergy to a fungus which is causing some manifestation. And what is the likely diagnosis? Based upon the clinical finding, if you get a case like this, one possibility you will consider is ABPA. What is ABPA? Allergic bronchopulmonary aspergillosis, right? There is a case scenario on this which has been asked in FMG and INI-CET. NEET PG में नहीं आया है, but FMG exam में it has been asked. Now, let us do a very brief quick review of ABPA topic. Now, ABPA is commonly caused by which fungus? It is caused by hypersensitivity to a fungus called as Aspergillus fumigatus. I hope you know कि Aspergillus nigricans और Aspergillus के बाकी subspecies are also there. But it is the Aspergillus fumigatus hypersensitivity which produces this problem. Risk factor I've already told you, bronchial asthma and cystic fibrosis. Secondly, what is the cardinal test? What is the test which if positive, you will not think of anything else? Detection of Aspergillus specific immunoglobulin E in the patient. This is very, very important. Has been asked as a one-liner in INI-CET exam, not in FMG exam, but can be a repeat in FMG exam. So cardinal test या most accurate test क्या है? It is detection of Aspergillus specific immunoglobulin E. It's mentioned in Harrison also. Other features include positive skin prick test to Aspergillus fumigatus extract or antigen. There will be prominent peripheral eosinophilia. So when you check the peripheral blood, you take out venous blood, you will find eosinophil count to be high. You will find that the circulating levels of immunoglobulin is high, more than 1000 units per ml, and you will find that chest X-ray as well as CT scan will show central bronchiectasis. Very, very important. Question asked in FMG exam past years. All of the following are seen in ABPA except one of the option was peripheral bronchiectasis, and that was the answer because central bronchiectasis is seen, not peripheral bronchiectasis. Then what is the treatment? It's an allergic disorder. Or to allergy mein what do you give? You give anti-allergic. The strongest immunosuppressant or anti-allergic medication is steroid. So systemic steroids are life-saving. Along with that, because you need to eradicate the fungal antigens and the fungal presence, so antifungal agents need to be given. What antifungal agents are indicated? Either itraconazole or voriconazole. Key thing to remember, fluconazole is not effective in patients of ABPA. अब ये फार्मा का क्वेश्चन है इन नीट पीजी एग्जाम. सो यहाँ पर साइड में लिख सकते हो कि fluconazole is not effective. It is not effective in patients of ABPA or serious aspergillus infections. तो किसी पेशेंट में आपको एस्परजिलस इन्फेक्शन मिले तो कौन सा एजेंट नहीं दोगे? It will be fluconazole. ऐसा नहीं कि दे नहीं सकते. If you don't have an option, you will give it. But itraconazole and voriconazole are most effective in it. Now moving further, sometimes क्या होगा कि patient will be refractory to even steroids and antifungal agent. और ये पेशेंट कौन से होंगे? सिस्टिक फाइब्रोसिस विद एज पर ABPA. तो ऐसे पेशेंट के अंदर यू नीड टू गिव monoclonal antibody called as omalizumab. It's a potential MCQ mentioned in the new edition of Harrison. Omalizumab कौन सी antibody होती है? It is anti-IgE monoclonal antibody which is useful in cystic fibrosis associated ABPA. So we have done is what we have done here is MCQ scenario discuss किया है and all the key points are related to ABPA also we have discussed, and some of the points are important from pharma and microbiology part also. That is why I have said it is an integrated session. Moving to there is a related term. What is fungal asthma? Fungal asthma confusion create करता है. Fungal asthma includes two entities. It includes ABPA as well as SAFS. So the question arises, what is SAFS? SAFS stands for severe asthma with fungal sensitization. There are many patients who are having severe asthma. उनके अंदर allergy है to Aspergillus fumigatus, but all the sensitive criteria which are present for diagnosis, they are not present. तो ऐसे पेशेंट को हम कहते हैं severe asthma with fungal sensitization. I hope you understand that there is a spectrum. इस स्पेक्ट्रम के एक एंड पे तो है ABPA, दूसरे एंड पे है milder variant called as SAFS. These patients have sensitivity to Aspergillus, but they are not having the full-blown ABPA. इन पेशेंट्स के अंदर क्या फीचर्स होते हैं? पहला तो this is not due to Aspergillus alone. This can happen due to other fungi also. Secondly, the serum total IgE is always less than 1000 international unit per ml. ये important clue है. वहां पर it was more than 1000 units. And bronchial wall thickening is also found in these patients, and fungal asthma also responds to immunosuppressive therapy like corticosteroids. Let us talk about MCQ scenario number 2. Examiner will put a question that there is a patient, there is an adult patient who is having old age or who is bedridden or who is having a post-operative surgery. Post-operative patient. Post-operative patients are mostly involving either total hip replacement, जहां पर hip को replace किया जा रहा है, और fracture neck of the femur. ये patients होते हैं जिनके अंदर ये entity is common, what we are going to discuss. So these are the important risk factor which the examiner will mention. Secondly, they will say that the patient with this risk factor, for example, bedridden old 60-year-old, 70-year-old patient suddenly develops acute onset dyspnea, that is breathlessness. Question will say that there is also pleuritic chest pain, sometimes worsening on deep inspiration, and the patient will be having tachycardia. Hypotension may or may not be present in the patient. So whenever there is a risk factor predisposing to thrombosis and there is sudden onset dyspnea with tachycardia with or without hypotension and pleuritic chest pain is present, you will think the likely diagnosis is going to be, yes, it is going to be PTE. What is PTE? Pulmonary thromboembolism. It is also called as pulmonary embolism in the patient. So let us do a quick review of the topic pulmonary thromboembolism. सबसे पहले we need to know what are the risk factor. क्या ये सब में हो जाता है? नहीं. Pulmonary thromboembolism does not occur in you and me. The risk factors relevant from entrance exam include अगर patient बहुत immobilized है, so prolonged immobilization. This is one risk factor. Second, if the patient is completely bedridden, उसकी कोई movement नहीं हो रही है, so deep venous thrombosis can happen and that can lead to pulmonary embolism. Thirdly, the patient will be post-operative. What operations are particularly associated with the risk of pulmonary thromboembolism? Particularly in case patient is having a total hip replacement or the patient is having surgery done for fracture neck of femur. ये दो surgeries हैं जिनके अंदर risk of pulmonary thromboembolism is specially high. सब में नहीं होता but they have a high risk. Fourthly, nephrotic syndrome patient, adult with nephrotic syndrome. Nephrotic syndrome, I hope you remember that it is a procoagulant state. Then there is a syndrome known as antiphospholipid antibody syndrome, जिसे हम कहते हैं APLA syndrome. So APLA syndrome is another risk factor. And then there is a genetic mutation, genetic abnormality called as factor V Leiden mutation. Factor V Leiden mutation. So these are the important risk factors mentioned in Harrison, which are the important risk factor where embolism can happen. Now investigation part we will discuss separately because उसके ऊपर बहुत fine questions आते हैं. Suppose there is a patient with pulmonary embolism, तो clinical feature क्या होंगे? Risk factor वाला patient developing sudden onset dyspnea with tachycardia with or without hypotension and dyspnea obviously will be present. Now treatment क्या करना है इन patients के अंदर? याद रखो कि whenever there is a patient with small or submassive का मतलब जो कि hemodynamic changes नहीं करता. This is not the correct definition, but this is the easy way to remember from MCQ perspective, right? देखो हमारा aim क्या है? Our aim is to crack the exam and to cross the line. तो आपने एक line सुना होगा. Journey is more important than destination. When it comes to entrance exam, destination is more important than the journey. Journey भूल जाओ. If you are able to get those 150 plus correct, you will get the degree in your hand. So rules matter नहीं करते. What matters is whether you are able to crack that line, cross that line or not, and that is what we are aiming in this session. तो मैं आपको concept बता रहा हूँ, but मैं बहुत जगह पर in a lot of places I am taking the shortcuts also, avoiding trying to just for the sake of sensationalism giving you some exotic reference or exotic concept. What I want to say is अगर question बोले small, asymptomatic, submassive pulmonary embolism है तो ऐसे patient के अंदर you don't need to lyse the जो clot बना है, you don't need to break it down. All you need to give in the patient is low molecular weight heparin. For example, enoxaparin या उसका कोई analog can be given. This is more than enough in these patients. लेकिन अगर if the MCQ says the patient is having a massive pulmonary thromboembolism or any pulmonary embolism patient where there are hemodynamic changes with, suppose patient का systolic blood pressure is less than 90 millimeters of mercury, तो hypotension हो गया है. ऐसे patient के अंदर low molecular weight heparin alone will not be effective. LMWH देंगे, but what will be the therapy of choice? Thrombolysis will be life saving. Thrombolysis is life saving. ये बहुत important है. And why am I stressing upon it? Because इसके ऊपर भी FMG का past question है, पुराना question 7 years back question होता है और ये 3 years back का question है. So thrombolysis is life saving. कौन सा thrombolytic agent you will prefer? You will give example alteplase. You can use reteplase. Rarely if nothing is available, you can use the cheaper agent called as streptokinase also. और सिर्फ thrombolysis से बात नहीं बनेगी. Low molecular weight heparin like enoxaparin will be given here also. लेकिन life saving क्या है? Thrombolysis. Small PTE के अंदर benefit is not there, but the risk of life-threatening bleeding is more. And so small embolism may you don't do thrombolysis, large embolism you do thrombolysis in the patient. So this is MCQ scenario number 2. As I promised, ECG changes, the investigation fine points are very frequently asked. So let us have a look at them. Now coming to extra edge thing, that is diagnosis of PTE. Why am I saying extra edge? Because a lot of difficult questions or sometimes atypical questions are asked in FMG exam. और ये आप लोग जो है, I know a lot of you, आप लोग शॉर्टकट मारते हो और वन लाइनर याद करके इसको इग्नोर करते हो. सो माई पर्पज इज कि वट एवर रीडिंग रिविजन यू आर डूइंग, यू डोंट मिस आउट ऑन दीज पर्टिनेंट आस्पेक्ट. सी, इसका मतलब ये नहीं है कि दिस इज गोइंग टू बी आस्क्ड फॉर श्योर, बट व्हाट आई एम ट्राइंग टू डू इज reducing your error ratio so that if a question is asked from an area where people go wrong, if a question is asked, you should not go wrong there, right? If you are listening to this video. तो सबसे पहले diagnosis के लिए कोई भी investigation में we do a screening test. If you remember PSM, screening test should be cheap, easily available. It should have a high sensitivity but a moderate to low specificity, right? ऐसा एक टेस्ट होता है what we call as blood for D-dimer assay. The question arises, what are D-dimer? D-dimers एक fibrin degradation products का एक reflect करता है, and D-dimer assays are, D-dimers are increased in the blood with patient with pulmonary embolism. They have high sensitivity but they have low specificity. Then we do a ECG in the patient. ECG में हमें दो चीजें मिलती हैं. First of all, what is the most common ECG manifestation? The most common ECG manifestation in the patient with embolism is sinus tachycardia. तो tachycardia arise तो sinus ऐसे नोड से करता है, but it is sinus tachycardia. So sinus tachycardia is seen. और अगर आपसे पूछे कि what is the characteristic lesion, characteristic or specific feature on ECG in pulmonary embolism, तो एक पैटर्न होता है what is called as QS1 Q3 T3 pattern. Very very important. ये जो पॉइंट है, this has been asked in FMG, NEET PG and as well as INI-CET exam. S1 Q3 T3 pattern. इसका एक ऑल्टरनेटिव नेम है, हो सकता है एग्जाम में वन लाइनर पूछे एंड यू डोंट नो द नेम ऑफ द साइन, तो याद कर लो, बिकॉज बहुत सारी आपकी करंट जो आप बुक्स पढ़ते हो या एप्लीकेशंस फॉलो करते हो, इट इज नॉट मेंशन्ड देयर. तो इसका नाम होता है मैकगिन वाइट साइन. मैकगिन वाइट साइन. मैकगिन वाइट साइन क्या है? Look at this ECG which has been shown. You will find that there are prominent S waves in lead 1. You will also find that there are prominent Q waves in lead 3, and lead 3 is also showing inversion of the T waves. So S1 Q3 T3 pattern, large S1 wave in lead 1, prominent Q wave in lead 3 and T wave inversion in lead 3 is called as the specific feature of pulmonary embolism on ECG. Then what is the investigation you will do to check for etiology or site of origin of embolus? देखो embolus से आया है तो कहीं से तो आया है. Usually it is coming from the calf veins. तो उसको आइडेंटिफाई करने का रीजन का इन्वेस्टिगेशन क्या है? We will do a ultrasound Doppler. And if you have appeared in the July 23 exam, this is a case-based scenario asked in July 23 FMG paper. कि etiology का मतलब cause identify करने के लिए for pulmonary embolism, where is the embolus arising from? You will do ultrasound Doppler of the lower limbs. So ultrasound Doppler of the lower limbs is recommended in these patients. Now, what is the investigation of choice for pulmonary embolism? It's a December 2021 FMG past MCQ, CTPA. What is CTPA? It stands for CT pulmonary angiography. Sometimes pulmonary word use नहीं करते, we use the word CT angiography. That is also the same thing. And what is the gold standard investigation? Ideal investigation, invasive, so we don't do it anymore. That is conventional angiography. So in this one particular slide, I have covered a lot of case scenarios and one-liners from various exams over the years, right? So ये extra edge point है. But this is not the only extra edge. Chest X-ray findings in pulmonary embolism are also asked in the exam. So obviously, what are the chest X-ray findings? On chest X-ray, you will find three signs. What are the three signs? सबसे पहले तो distal to the embolus, there will be a localized area in the lung parenchyma जहां पर oligemia हो जाएगा. देखो ना, try to understand. Blood supply restrict हो गया, क्योंकि clot आ गया, तो उसके distal area में क्या होगा? The blood supply will be reduced. उस focal oligemia को कहते हैं हम sign known as Westermarck sign. सेकेंड साइन क्या होगा, विच इज वेरी कॉमनली सीन अमंग दीज साइंस, उसमें क्या होता है कि देयर इज अ वेज शेप्ड डेंसिटी प्रोड्यूस होती है. पेरिफेरल, पेरिफेरल का मतलब टुवर्ड्स द प्लूरा, तो प्लूरा के आसपास एक ऐसा वेज शेप्ड डेंसिटी प्रोड्यूस होगा विच विल बी रिफ्लेक्टिव ऑफ इनफार्क्ट हैपनिंग ड्यू टू पल्मोनरी एम्बोलिज्म. इसको कहते हैं हैम्पटन सम. एंड थर्डली इज द पालस साइन, which is enlargement of the right descending pulmonary artery. If you try to do Google search, you will show you 7 or 8 radiological sign, but are they relevant for FMG exam? नहीं. उतना खाना है जितना डाइजेस्ट हो सके और उतना याद करना है जितना रिवाइज हो सके, एंड इट इज रेलेवेंट फॉर द एग्जाम, राइट? दैट इज द की थिंग. सो दीज आर द थ्री साइंस, वेस्टरमार्क साइन, हैम्पटन हम एंड पाला साइन सीन इन पल्मोनरी एम्बोलिज्म. अब इसमें से कौन सा चीज कॉमन है एंड विच कैन बी आस्क्ड एज अ विजुअल क्वेश्चन? विल से देयर इज अ पेशेंट विद प्रोलॉन्ग्ड इमोबिलाइजेशन, acute onset dyspnea, some chest pain, some tachycardia, and S1, Q3, T3 pattern. X-ray is shown below. What is the likely diagnosis? तो ये क्या दिख रहा है हमें? Can you see this wedge-shaped opacity which is produced? This wedge-shaped opacity is what you call as Hampton's hump. तो याद कर लो, ये फोटो है. This is what is suggesting Hampton's hump in the patient, right? Let us move further and talk about an MCQ asked in January 2023 paper. 60-year-old bedridden patient develops sudden onset breathlessness and acute chest pain. What is the best investigation to make the diagnosis? ये January 23 का question है. Screening test is D-dimer assay. Helpful test is ECG. But what is the investigation of choice? It is angiography. Gold standard is conventional, but investigation of choice is CT pulmonary angiography, and that is your answer. Right? Question MCQ scenario number 3. Now examiner will say there is a patient, there is a adult patient who's having productive cough. Cough is more in the morning hours, right? And there is yellowish sputum which increases with change in posture. तो क्या हो रहा है कि overnight there is increased production of sputum, productive cough. वो sputum accumulate हो रहा है and posture change होने से and getting up in the morning that is coming out. So something causing dilatation of the airway where sputum is getting collected. That is the clue. That is what this means. देखो हर लाइन का मतलब होता है. You need to understand the meaning. If you understand the meaning, it becomes very easy for you. I am a clinician. When I sit in my OPD, मुझे incubation period और X-ray finding नहीं पता होते हैं. Patient comes to me and gives me the history. Based upon those, I advise investigation, and sometimes I just assume and write the treatment for that. So if the patient is saying a dry cough, तो you will think of some atypical things. You will not think of something which is where sputum is getting collected like tuberculosis or bronchiectasis. लेकिन ऐसे patient के अंदर you will think of those condition. So productive cough, yellow sputum changing with posture, and there is fever present with or with plus or minus, clubbing of the digits may occur. If you get a scenario like this, there is a case scenario asked on this, so I'm putting a Q. The likely diagnosis in the patient is going to be bronchiectasis. So the question arises, what is bronchiectasis? तो एक brief review करते हैं. Bronchiectasis refers to abnormal, irreversible dilatation of the bronchi. That is called as bronchiectasis. Now there are multiple ways of defining bronchiectasis in the patient. Bronchiectasis can be either focal, एक limited area में, or it can be diffuse. अगर focal हो रहा है तो usually it occurs due to a local cause. कोई local area है जो उस specific bronchus का dilatation कर रहा है. This local cause can be either extrinsic compression, or it can be an intrinsic compression in the bronchus itself. Whereas if it is a diffuse bronchiectasis, you should suspect a systemic cause in the patient. कोई सिंड्रोम हो सकता है, कोई टीबी जैसा कंडीशन हो सकता है, कोई सिस्टेमिक condition causing immunosuppression हो सकता है sometimes, right? That is going to cause a diffuse bronchiectasis in the patient. It is rarely also categorized into two forms called as central as well as peripheral. देखो पेरिफेरल ब्रोंकिक्टेसिस जो होता है वो पेरिफेरल ब्रोंकाई को इन्वॉल्व करता है, एंड देन वी हैव द सेंट्रल ब्रोंकिक्टेसिस. सेंट्रल ब्रोंकिक्टेसिस यूजुअली it is seen in patients with ABPA and it is used in patients with cystic fibrosis. ये एक obsolete classification है which has been discarded, but examiners are still fond of it, and if you see the question in 2019 there is a question on this. Central bronchiectasis किस में मिलता है, and ABPA was not in the option. Your answer was cystic fibrosis in those patients, right? तो इसमें obviously patient के features क्या होंगे? There will be a underlying respiratory illness, sometimes no feature, productive cough, more in the morning, productive sputum, yellow colored sputum, and increasing with change in the posture. Fever plus minus, clubbing plus minus. What are the radiological signs of bronchiectasis? Radiological signs क्या होते हैं bronchiectasis के? तो कुछ साइंस है जो हमें याद रखने हैं. फर्स्ट ऑफ ऑल, द साइन विच इज सीन ऑन बोथ चेस्ट एक्सरे एज वेल एज सीटी स्कैन इज ट्रैम ट्रैक साइन. तो ट्रैम ट्रैक साइन और रेलवे ट्रैक साइन इज सीन इन दीज पेशेंट्स. दूसरा होता है सिग्नेट रिंग साइन, सिग्नेट रिंग साइन. और तीसरा होता है ट्री इन द बड साइन. सो दीज आर द थ्री साइंस which have been described in patients with bronchiectasis. If they ask you old MCQ in FMG exam, what is the investigation of choice in bronchiectasis in the patient? It is always HRCT. High resolution CT scan is the investigation of choice. If HRCT is not in the option, you can simply mark CT scan as the answer. और treatment क्या होगा patients के अंदर? Treatment in bronchiectasis will always be treat the cause. जो भी cause है, whichever it has caused, you will treat the cause. Plus, because there is infection present, stasis happening, so antibiotics will need to be given along with local measure to remove the accumulated mucus and focus of infection. तो आप दोगे chest physiotherapy in the patient. I am writing as chest PT physiotherapy, and you will do nebulization in the patient. So saline nebulization or nebulization with specific agents can be indicated in bronchiectasis. So this is a quick review, focused review of the topic of bronchiectasis. Let us move further and talk about the MCQ scenario number 4. MCQ scenario number 4 will say there is a patient, adult patient, who's having fever, he's having cough, he's having dyspnea, that is shortness of breath. Patient is having bronchial breathing. This is the first clue. Bronchial breathing हो रहा है. And the patient is also having chest x-ray showing either lobar consolidation or infiltrates non-specifically in the patient. तो जब भी patient में fever, cough, dyspnea, bronchial breathing and localized consolidation या infiltrate होंगे, obviously the likely diagnosis is going to be pneumonia in the patient. I hope you remember कि in children pneumonia diagnosis is made based upon fast breathing and chest indrawing, but in adults it is a combination of clinical feature and auscultation, percussion and auscultation findings and chest x-ray findings. So pneumonia is the likely diagnosis here. Now regarding pneumonia, there are a lot of MCQ one-liners we need to remember. At least 5 or 6 of them, the points which I am going to write, are past MCQs. तो अगर MCQ पूछे pneumonia का adult के अंदर, what is the overall most common cause? The overall most common cause is always Streptococcus pneumoniae, which is also called as pneumococcus. The most common cause is pneumococcus. If MCQ asks you what is the most common cause of nosocomial pneumonia, what is nosocomial pneumonia? Hospital acquired pneumonia in adults. The answer will be Staph aureus. If the examiner says there is a COPD patient which develops pneumonia in the patient, what is the likely organism? According to table given in Harrison, it is Haemophilus influenzae. Haemophilus influenzae in these patients. And if the MCQ says there is a patient who's having HIV associated pneumonia, तो most common cause of pneumonia क्या होगा? That will be pneumocystis. I'm writing with a different color because this is a recent MCQ point. Pneumocystis girovecii, and that is the answer. So HIV या AIDS पेशेंट में निमोनिया का सबसे कॉमन कॉज ओवरऑल क्या होता है? इट इज न्यूमोसिस्टिस जीरोवेकी. अब ये एक बहुत इंपॉर्टेंट पॉइंट है कि causes of pneumonia, I'm giving a heading, it's a separate subtopic in this, causes of pneumonia in HIV positive patient. इसको कैसे याद रखना है? बड़ा सिंपल है, ये डिपेंड करता है CD4 काउंट के ऊपर. If the CD4 plus count, I hope you remember that CD4 plus count determines the level of immunosuppression in the patient. If the CD4 plus count is less than 500 per millimeter cube, तो कौन सा कॉज ऑफ निमोनिया होता है? इट इज कॉमनली कॉज्ड बाय माइकोबैक्टीरियम ट्यूबरकुलोसिस. तो टीबी बेसिलाई इज कॉमन इन दीज पेशेंट्स. If the question says CD4 plus count falls below 200 per millimeter cube, तो ऐसे पेशेंट्स में द कॉजेटिव एजेंट इज गोइंग टू बी न्यूमोसिस्टिस जीरोवेकी. And if the question says level falls below 50 per millimeter cube, the causative agent in the patient is going to be MAI. What is MAI? It stands for atypical mycobacteria called as Mycobacterium avium intracellulare. This is the most common pathogen in these patients, right? क्या इसके ऊपर क्वेश्चन है? Yes, इसके ऊपर recent FMG MCQ है, case scenario MCQ है. And lastly, if MCQ asks you, see मैं वही कर रहा हूँ which is important from your entrance perspective, right? If the MCQ says there is a patient, उसमें निमोनिया हुआ, निमोनिया पेशेंट, उसमें हिस्ट्री है, there is वो एक कॉन्फ्रेंस में गया where there was contaminated AC unit. तो AC में जो कूलेंट यूज होता है उसका कंटेमिनेशन हुआ है या एरोसोल रूट से स्प्रेड हुआ है, एरोसोल स्प्रेड है. दूसरा क्लू क्या होगा? पेशेंट विल बी हैविंग हाइपोनेट्रीमिया इन निमोनिया. और तीसरा क्लू क्या होगा? देयर विल बी नो क्रेपिटेशंस एंड नो लोबर इनफिल्ट्रेट. एटिपिकल निमोनिया फीचर्स विल बी प्रेजेंट इन द पेशेंट. सो ड्राई कफ होगी पेशेंट के अंदर एंड इंटरस्टिशियल इनफिल्ट्रेट होंगे. तो ऐसे पेशेंट्स के अंदर लाइकली डायग्नोसिस क्या होगा? इट इज गोइंग टू बी लीजियोनेला न्यूमोफिला. सो लीजियोनेला इज द कॉज ऑफ, also called as Legionnaires disease, is the cause of pneumonia in these patients. और Legionella pneumophila में क्या एजेंट यूज करते हैं? इट्स अ फार्मा क्वेश्चन. द फर्स्ट लाइन ड्रग और इसमें ड्रग ऑफ चॉइस नहीं होता है क्योंकि दोनों ड्रग इक्वली इफेक्टिव हैं. यू कैन यूज आइदर फ्लोरोक्विनोलोन्स like ciprofloxacin or levofloxacin, or you can go for high dose azithromycin, that is macrolides, right? So ये case scenario है. In one slide I have covered 5 MCQs. Out of them 3 are case scenarios and 2 are one-liners of FMG exam. So every slide I am making, I am discussing with you. Trust me, I have spent some time looking at your past papers to make sure that you get the highest yield. अब इसमें क्वेश्चन आएगा कि नहीं आएगा? You ask me often कि सर क्या इसमें से पक्का आएगा? See, I am not an astrologer. What I can tell you is this is what you should know. So whatever preparation you are doing, इसको एक बार देख कर जाना है. Ideally 2 बार देख कर जाएंगे तो बहुत कॉन्फिडेंस रहेगा, बहुत सेफ रहेगा, right? Let's move further. Look at MCQ. Before we go to MCQ scenario, curve 65 criteria. Curve 65 criteria क्या है? इसके ऊपर there is a past 3 years back MCQ asked in FMG exam. Curve 65 criteria predict करता है, it predicts the mortality in CAP. What is CAP? CAP stands for community acquired pneumonia. It predicts mortality in patients with community acquired pneumonia. और इसका टेबल क्या है? Let us look at the table. Curve 65 में 5 features are there. C stands for confusion. और इसके लिए एक पॉइंट देते हैं. U stands for urea more than 7 millimoles per liter. This is 1 point. Then we have R, which stands for tachypnea, respiratory rate equal to more than 30, which is 1. B stands for blood pressure changes, either systolic BP less than 90 or diastolic BP less than 60. You will give as 1. दोनों है तो एक ही देंगे. अगर दोनों में से कोई भी एक है तब भी एक ही देंगे, राइट? एंड 65 stands for age more than 65 year is more than 1. If you find that the total score of curve 65 score is 0 to 1, तो risk group 1 है, 30-day mortality 1.5% है, you can treat at home with oral antibiotics like levofloxacin or amoxiclav in the patient. If the curve 65 score is 2, तो risk group 2 है, 30-day mortality almost 7 to 8 times बढ़ जाती है, 9.2%. और ऐसे पेशेंट में you have to take a clinical decision, admit करना है. प्राइवेट सेक्टर में well to do patient, admit the patient. Very poor patient, OPD basis, but follow up the patient. Or if the curve score is 3 to 5, risk group 3, 22% mortality is there, and so 22% का मतलब क्या है? 5 पेशेंट में से एक मर जाएगा. 1 out of 5 patients will die almost, and so all of them need to be admitted, managed as severe, and they will always require IV antibiotics in the patient. So curve 65 criteria बहुत useful clue है. Tomorrow when you are sitting in an emergency room, you crack your exam of FMG, you do party, you give interviews, you say your thanks, you spam the relatives who have doubted you. After that cycle is over, you will be joining your internship. And when you join your internship, pneumonia patient night 12:30 will be coming to you. Curve 65 criteria is going to tell you कि इसको कितना aggressively manage करना है, right? Obviously, you will be taking the help of your on-duty doctors and seniors, but this curve 65 criteria is useful in a clinical setting. Moving further, we have next scenario. MCQ January 2023 question easy hai. Let us see if you can solve it. So question says HIV positive patient developed pulmonary infection, CD4 plus count is 50 cells per millimeter cube, right? Sputum was positive for acid fast organism, which is the likely cause. Pneumocystis jirovecii जो होता है, that causes infection in patients CD4 count less than 200. यहाँ पर है 50 cells per millimeter cube. हो सकता है, लेकिन नोकार्डिया ऐसे पेशेंट में नहीं होता, स्टॉफ ऑरियस नहीं होता. So option is between B and D. लेकिन we know that if the count is 50 or less, Mycobacterium avium intracellular is more common. And second thing, the clinching point, acid fast organism. Pneumocystis jirovecii acid fast नहीं होता. Mycobacterium pathogens are acid fast, and that is the second clue, and that is why the answer in this question is B, that is Mycobacterium avium intracellular. It is the January 2023 FMG MCQ. It is the MCQ asked in January 23 paper. Let us move further and talk about MCQ scenario number 5. Now, examiner will say that there is a patient who's having fever, hemopsis, that is bleeding in the cuff. Patient is also having weight loss and loss of appetite. Weight loss, loss of appetite, you know where this is going. And hemopsis जो होता है वो regular नहीं होता, intermittent होता है. Smoking history is present. Mostly smoker होते हैं, but जरूरी नहीं है. Can occur in non-smokers also. And the patient will show chest X-ray showing either a widening of the mediastinum or collapse in specific segments of the lung. So ऐसे patient के अंदर the likely diagnosis is going to be cancer of the lung. We call it as bronchogenic carcinoma. Let us do a quick review of bronchogenic carcinoma. Bronchogenic carcinoma के 4 types होते हैं. There are 4 types of bronchogenic carcinoma according to WHO. There are rare subtypes also. 4 types होते हैं. The first variety is called as small cell lung cancer. Second variety is called as squamous cell cancer. Third variety is called as adenocarcinoma. And fourth variety is called as large cell carcinoma. ये 5 to 10% होता है, so ये rare होता है. If you see the 3 varieties, the varieties of squamous cell, adeno and large cell are also called as non-SCLC, non-small cell lung cancer, whereas small cell cancer is also called as SCLC. SCLC stands for small cell lung cancer. So this is the classification, the 4 varieties that you need to remember. And कौन सा पेशेंट है, कौन से 2 ट्यूमर्स हैं जो कि स्मोकर्स में कॉमन है? स्मॉल सेल एज वेल एज स्क्वेमस सेल आर मोर कॉमन इन स्मोकर्स. And if MCQ examiner asks you which is the most common tumor seen in non-smokers, the answer is adenocarcinoma. MCQ point. If the MCQ says एक asbestosis patient है, what is the most common tumor seen in the patient? The answer again will be adenocarcinoma, right? तो ये key points है. देखो देखने में लग रहा है कि मैंने 4 पॉइंट ही लिखे हैं, but if you see carefully every word which I have mentioned, it has a MCQ relevance for the exam. Now some one-liners we need to remember. First one-liner is, are paraneoplastic syndromes common in bronchogenic carcinoma? Yes, paraneoplastic syndromes are more common in small cell lung cancer. तो नॉन स्मॉल सेल के अंदर ये कम देखे जाते हैं. Secondly, small cell lung cancer are found positive for neuroendocrine markers. So immunohistochemistry पे how can you distinguish them from the other forms? Small cell lung cancer will be positive for CD56. So first thing is, all the small cell lung cancers are CD56 positive. They are chromogranin positive. They are synaptophysin positive. Last but not the least, they are also NCAM positive. तो ये 4 ट्यूमर मार्कर हैं जो हैरिसन एंड रॉबिन्स दोनों में मेंशन्ड है, कैन बी आस्क्ड इन द एग्जाम. तो क्वेश्चन आते हैं, देखो ट्रीटमेंट के अंदर ऑब्वियसली इट विल बी अ कॉम्बिनेशन ऑफ सर्जरी अलोंग विद कीमो प्लस माइनस रेडियोथेरेपी. समटाइम्स पैलिएशन विल बी नीडेड. मेटास्टेसिस आर वेरी कॉमन इन देम. सो यूजुअली दे कम टू अटेंशन क्वाइट लेट एंड द आउटकम इज नॉट दैट ग्रेट. लेकिन डायग्नोसिस हाउ बनाएंगे कैसे? हाउ वुड यू मेक द डायग्नोसिस? सो रिमेंबर how to make the diagnosis. For the purpose of diagnosis, obviously you need to do biopsy, right? If it is a peripheral आपने एक्सरे किया या सीटी किया and you found a peripheral lesion, suspected bronchogenic carcinoma periphery में है, तो ऐसे पेशेंट के अंदर what will be the investigation of choice? It will be CT guided transthoracic biopsy. So through the thorax under CT guidance you will take biopsy in the patient. क्या ये क्वेश्चन है? यस, इट इज अ जनवरी 23 एफएमजी क्वेश्चन. एफएमजी का क्वेश्चन है ये, रिसेंट लास्ट ईयर का क्वेश्चन है. एंड इफ द क्वेश्चन सेज इट इज अ सेंट्रल लीजन, सपोज आपने एक्सरे किया और सेंट्रल लीजन या ब्रोंकस के अंदर लीजन मिला, तो ऐसे पेशेंट के अंदर व्हाट इन्वेस्टिगेशन वुड यू लाइक टू डू? यू वुड लाइक टू डू ब्रोंकोस्कोपिक बायोप्सी. सो यू विल डू अ ब्रोंकोस्कोपिक एंड टेक बायोप्सी फ्रॉम दैट. If that is not possible and that fails, then you can go for CT guided transthoracic biopsy. छोटा छोटा लिख रहा हूं, but I don't want to create too many slides because I know you have to revise also. सास भी कभी बहू थी. The teacher has been a student once and I know number of pages that you have, that also plays on your mind in the last week before the exam when it comes to revision. 100 पेज होंगे आप छोड़ दोगे, 40 पेज होंगे तो आप रिवाइज कर पाओगे. एंड दैट इज व्हाट आई एम ट्राइंग टू डू इन दीज रिवीजन सेशंस. So some of you ask me, sir, why do you take so much of time in putting up the video? See, putting up these questions, it will take hardly 2 hours, 3 hours max. But there is a process I follow. I look at your past papers, I edit, re-edit, edit, re-edit, and then I try to see whether you will be able to revise it in the last 2 weeks or not, and then only I put it. Takes time, right? So I hope you understand, and there are other reasons which I will summarize at the end of the video. So MCQ scenario number 5 is done. Let us look at MCQ. There is a funda to remember. What is the funda to remember here? The funda is that asbestosis patient, I told you, they have an increased risk of malignancy, right? तो कौन सा common malignancy है? Now mesothelioma सबसे common नहीं होता. That is the common mistake students do. If they say what is the most common tumor in asbestosis, the overall most common tumor or cancer is non-small cell lung carcinoma. I just told you it is adenocarcinoma of the lung. But if they ask what is the most specific, जो सिर्फ इसमें होता है, that is mesothelioma of the pleura, and this is a January 2023 FMGE MCQ. Right? याद कर लो, फंडा नहीं है, just something to remember. And then we look at MCQ scenario number 6. Examiner will say that there is a patient, there is an adult patient who's having known infection, some respiratory disease या trauma हुआ patient, and the patient developed dyspnea, shortness of breath. Patient has decreased air entry on one side and unequal breath sound या एक तरफ breath sound absent ही है. And you also found that there is hyper resonant node. I hope you know that stony dull node indicates fluid collection, pleural effusion. Hyper resonant node indicates air collection. So pneumothorax की तरफ जा रहा है, right? तो ये word बड़ा important है, याद कर लो इसको, hyper resonant node. And then chest X-ray will show two signs, either deep sulcus sign or loss of vascular markings on the affected side. Why loss of vascular marking? Because air trapping is happening, so vascular markings will not be visible. So the likely diagnosis in the patient obviously is going to be pneumothorax, right? Air collection in the pleural cavity. There can be a closed pneumothorax, there can be an open pneumothorax. The life-threatening form is called as tension pneumothorax. So उसमें क्या होता है? There is a not only collapse of the ipsilateral lung but also compression and mediastinal shift may happen, leading to severe respiratory distress which can be life-threatening in the patient, and sometimes hemodynamic changes can also happen in the patient. So that is called as pneumothorax. So photograph, let me show you the photograph. Look at this X-ray. ऐसा photo दे सकते हैं. Similar X-ray has been asked in the exam, and they will say patient में unequal breath sounds था. Tell me the diagnosis. Can you see that on the right side, एक तो number of hyperinflation has more. Secondly, can you see the bronchovascular markings have disappeared in all these spaces, right? And सबसे importantly, can you see कि sulcus on the right side, ये sulcus deep हो गया. Let me mark it here. ये sulcus deep हो गया. इस साइन को कहते हैं deep sulcus sign. This is what you call as the deep sulcus sign. Yes, deepening हो गई है black colored marking case. That is called as deep sulcus sign. So that is called as pneumothorax. So the only thing they will ask you to do in the exam is pneumothorax में क्या करना है. If it is not a tension pneumothorax, you can simply put a intercostal tube, and sometimes if it is a mild or incidentally detected, you can do observation also. But if the MCQ says that there is a patient having tension pneumothorax, patient having tension pneumothorax, I'm writing like this in short. तो ऐसे patient में आप करोगे, you will decompress the lung because ipsilateral lung has decompressed already. वो collapse हो गया. So decompression should be done by needle. इस procedure को हम क्या कहते हैं? We call it as needle decompression procedure. This procedure is called as needle decompression procedure. और ये कौन सी किस एरिया में करते हैं मोस्ट कॉमनली? अगेन इट विल डिपेंड अपॉन द पेशेंट. पीडियाट्रिक पेशेंट्स के अंदर हम फर्स्ट और सेकंड इंटरकोस्टल स्पेस में भी एटिपिकल केसेस में करते हैं, बट इन केस ऑफ एडल्ट इट इज मोस्टली डन इन द मिड एक्सिलरी लाइन in the fourth or fifth intercostal space. Again it will depend upon the status of the patient. Let me be clear. और इसके ऊपर MCQ नहीं आता है, लेकिन commonly किस एरिया में करते हैं? यहीं पर करते हैं. और after you have decompressed, you will not stop here. You will also do ICDT, intercostal drainage tube insertion at the same level. Right? They're unlikely to ask you the fine details of pneumothorax. All they will ask you is to make the diagnosis, or they can give you an X-ray and they can ask you कि urgent therapy किसमें करना है. Tension pneumothorax patients, you need to do urgent therapy. Let us move to the next MCQ scenario. Now have a look at MCQ scenario number 7. Question will say, examiner will say, there is a patient who is having hemopsis. Hemopsis will be blood present in the sputum. So on coughing, there is blood coming out. Associated with hematuria, usually it is gross hematuria. Rarely it can be sometimes microscopic hematuria also. So bleeding in the coughing, and bleeding is also present in the urine. And there will be presence of anti-GBM. GBM stands for glomerular basement membrane antibodies. Very similar question has been asked to you in January 2023 of FMGE exam. So if you have hemopsis, hematuria and anti-GBM antibody positivity, the likely diagnosis in the patient is going to be Goodpasture syndrome. So Goodpasture syndrome is an autoimmune condition in which autoantibodies form against epitopes, antigens present in the glomerular basement membrane. So let us write down the key points about Goodpasture syndrome. Let us summarize the topic here. Now, Goodpasture syndrome, what is the age in which Goodpasture syndrome occurs? There are broadly two ages. There are two peaks of age groups where this condition is commonly seen. First are men, that is males, between the age of 20 to 30 years. And second peak is seen in both males as well as females who are in the age group of 60 to 70 years. These are the patients. The men patients are the ones who are going to have a combination of hematuria along with hemopsis. And these are the patients who present more dramatically. But ironically, it is seen that the outcome in the patient is actually better in them. So hematuria with hemopsis, both of them is present, sometimes associated with fever, dyspnea, fall in the hemoglobin level, etc. So massive pulmonary and massive renal bleed will be seen in men. On the other hand, males and females 60 to 70 year, they will be presenting with isolated hematuria. Hemopsis is usually rare in them. So you might be thinking if isolated hematuria is there, the outcome acha hoga. No. The antibodies have been there for so long that if the patient presents in 60 to 70 years, the outcome is actually poor and most of the kidneys are now destroyed. So even if the pulmonary manifestations are missing, these patients are found to have a relatively poor outcome. So remember, agar late presentation aayega, so they will have a poor outcome. Jaldi aayega, jaldi detect hoga, you will be able to give immunosuppressants, anti-inflammatory agent and control the production of autoantibody. This is the first concept to understand. Second concept to understand is kaun si antibodies banti hain. So what are the autoantibodies formed in them? The autoantibodies are called as IgG type of anti-GBM. GBM stands for glomerular basement membrane antibodies. और ये किसके against directed होती हैं? These are directed against a specific epitope. What is the epitope? There is a alpha 3 NC1 domain found on type 4 collagen. अब हमें पता है कि type 4 collagen basement membrane का part होता है और ये type 4 collagen is found in alveolar basement membrane as well as in the glomerular basement membrane, and that is why the antibodies attack and cause bleeding in the adjacent capillaries in the glomeruli as well as in the alveoli. So alveolar hemorrhage hota hai in patients ke andar, alveolar bleeding happens leading to hemopsis. So type 4 collagen के against बनती है, इसके ऊपर standalone MCQ point भी है. So where are the antibodies directed against? Against type 4 collagen. Also it is seen that if the patient is having isolated hematuria without any pulmonary involvement, isolated hematuria होगा, bracket only renal disease, only renal hemorrhage, तो ऐसे patient के लिए हम term use करते हैं anti-GBM disease. तो बहुत सारी बुक्स में इनको similar माना जाता है, but they are actually not the same if you see technically. If both lungs and glomeruli are affected, उसे कहते हैं Goodpasture syndrome. If only kidneys are involved and there is no hemopsis present in the patient, उसे कहते हैं anti-GBM disease, and this distinction is very clearly mentioned in Harrison as well as Robbins, right? So obviously what will be the treatment in the patient? So Goodpasture syndrome का treatment क्या रहेगा? Treatment of Goodpasture syndrome as well as anti-GBM disease same होता है. You start the patient on plasma exchange, we call it as plasma apheresis. So we do multiple cycles of plasma apheresis. Along with that, we give anti-inflammatory immunosuppressive agents. So you give prednisolone in high dose, gradually you taper it. Along with that, many patients, particularly those with hemopsis, will also require cyclophosphamide for a short duration. And then maintenance agents with maintenance doses of low dose prednisolone, azathioprine, mycophenolate mofetil, ये सब agents may be needed, and this will vary from person to person. So combination therapy is used, plasma apheresis, plasma exchange से we remove the antibodies, and prednisolone and cyclophosphamide are often added to it. And if someone asks you what are the patients who are having a poor prognosis, poor prognosis किस patients में देखा जाता है? I have already told you, old age में if the presentation occurs, it has a poor prognosis. If the patient presents with oliguria, Poor prognosis if the patient presents with crescent formation on kidney biopsy. और कितने crescents? More than 50% glomeruli are affected with crescents. That has a poor prognosis. किसी patient में आपको मिले कि serum creatinine is more than 4 to 5 milligram per deciliter. That has a poor outcome. On the other hand, if it is a young patient and there is a mixed presentation means हेमेचूरिया भी है, हिमोप्सिस भी है, they have a relatively better outcome. देखो दोनों चीजें खराब हैं, but which has a relatively better outcome? Young patients are found to have a relatively better outcome. And also remember a key point कि ये जो हिमोप्सिस होता है इन patients के अंदर, this hemopsis is triggered by smoking. And many times smokers come to attention. Smoking Goodpasture syndrome patients come to attention when they have a high smoking frequency and suddenly they develop that coughing episode and that triggers alveolar hemorrhage in the patient. So this is the key small review I have done for the Goodpasture syndrome. I have also covered points related to pathology part that you might be asked in the exam. Now let us have a look at MCQ scenario number 8, and it can be a child or an adult patient, and it is something which I'm very fond of teaching, but I will not go overboard. So the question will say there is a child or adult patient. The patient is having malabsorption and steatorrhea is being produced. What is steatorrhea? Fatty, bulky, sticky stool. So fat malabsorption is there. Along with that, there is recurrent pneumonias in the patient. There is recurrent nasal polyps. There is sinusitis in the patient, and there is a metabolic abnormality called as hypochloremic alkalosis. So जब भी MCQ examiner will say recurrent pneumonia, recurrent respiratory infection with fat malabsorption, तो सबसे likely condition क्या होती है? It is likely to be cystic fibrosis. So we are going to do a quick review of cystic fibrosis, all the relevant points here. Cystic fibrosis, first thing, it is a autosomal recessive condition. So it is an inherited condition which shows autosomal recessive inheritance. That is the first point. Second, what is the gene of cystic fibrosis? It involves a gene called as CFTR gene. CFTR stands for cystic fibrosis transmembrane regulator. This codes for a channel known as chloride channel. This chloride channel is found in various epithelial surfaces, and the absence of this channel is responsible for producing cystic fibrosis. CFTR gene कौन से क्रोमोसोम पे होता है? It is present on chromosome 7q. ये याद कर लो और इसके ऊपर MCQ है. बहुत सारे लोग याद कर लेते हैं कि क्रोमोसोम 7 है, but they falter if the option is 7p and 7q. So it is long arm of chromosome 7 where this gene is found. So ये क्लोराइड चैनल का फंक्शन क्या है? आई विल जस्ट एक्सप्लेन इन वन लाइन दैट नॉर्मली द फंक्शन ऑफ दिस क्लोराइड चैनल इन रेस्पिरेटरी ट्रैक्ट एंड गट इज टू सिक्रीट क्लोराइड, राइट? तो क्लोराइड सिक्रीट होने से क्या होता है? सोडियम ऑल्सो कम्स. Sodium chloride pulls water and the secretions in the lumen of respiratory and GI tract become watery. So when you do coughing, those secretions can be removed. Now what will happen in cystic fibrosis? Chloride channel is not functioning or not there. So what will happen? Chloride will not come into the lumen. Sodium will also not come. And so the secretions will become dehydrated. They will become impacted. Mucus जो होगा वो फंस जाएगा. The mucus will get impacted in the respiratory tract. There will be colonization by staph and pseudomonas, and this will cause recurrent pneumonias. So I hope you understand, right? Reverse happens in sweat gland ducts. In the sweat gland ducts, the function of chloride channel is to preserve chloride. So when there is absence of chloride channel, so chloride and sodium due to passive transfer will be lost in the sweat. So excessive sodium chloride loss will cause hypochloremic alkalosis. So what will be the key features here? I have already written either child or adult. Malabsorption, that is steatorrhea, will happen. Fatty stools. Pancreatic dysfunction is responsible for this. Recurrent pneumonias can happen. Nasal polyps and sinusitis can develop. And what is the most common gene mutation which is responsible for producing cystic fibrosis? There is a mutation called as delta F508. इसका recently नाम change हुआ है. Now we call it as deletion 508 phenylalanine, PHE. And this is a recent NEET PG question also, can be asked in the exam. So सबसे common mutation कौन सी होती है? It is delta F508, now called as deletion in 508 position of phenylalanine residue. And this is considered to be a type of class 2 mutations. क्लास 1 से लेके क्लास 6 तक म्यूटेशंस के क्लासिफिकेशन है which you need not go into detail, but remember that most of the cystic fibrosis occurs due to class 2 mutation which are severe. Now cystic fibrosis के अंदर why does hypochloremic alkalosis happens? Because there is increased sodium chloride loss. Increased sodium chloride loss in the sweat glands, which leads to dehydration along with hypochloremic metabolic alkalosis. Also remember that in the first decade of life, you will find that these patients are having, exocrine pancreatic insufficiency. And on the other hand, once second decade begins, second decade में exocrine तो चलता ही है, along with that endocrine pancreatic insufficiency also appears. That is, type 1 diabetes mellitus risk increases in second decade of life onward. तो 5 साल के बच्चे में cystic fibrosis में what will not be seen? Diabetes mellitus will not be seen. So 2 types of MCQs can be asked. Can diabetes mellitus occur in cystic fibrosis? Yes, if they ask in general. Can it occur in a 5-year-old or 7-year-old child? The answer is no, because in the first decade only exocrine insufficiency is there, which is causing malabsorption. In the second decade of life, due to a variety of reasons, the endocrine part also gets involved, and so diabetes mellitus along with steatorrhea along with recurrent pneumonias will occur in the patient. And in case pneumonias are happening, what is the most common cause of pneumonia? Pneumonias in cystic fibrosis, if the age of the patient is less than 18 years, young children, it is mostly caused by Staph aureus, followed by mucoid species of Pseudomonas or Pseudomonas aeruginosa. And if question says adult patients, the undisputed king is Pseudomonas. So green colored sputum is produced in these patients, and it is the mucoid strains of Pseudomonas which are responsible for producing it. There was a very recent question asked in INI CET exam also, where they asked what happens to chloride secretion in sweat gland duct and pancreatic duct. Option कैसे थे? Both are increased, both are decreased, increased in sweat, decreased in pancreas, increased in pancreas, decreased in sweat, and so on. तो याद कर लो, if you get a similar question, chloride secretion is reduced in cystic fibrosis. It is reduced in gut as well as in respiratory tract. That is why secretions are becoming dehydrated. On the other hand, chloride secretion is increased in sweat gland ducts, right? And that is why hypochloremic alkalosis and loss of chloride, sodium chloride, is happening in the patient, right? If you solve MCQ, you would realize every single sentence I have said in this topic, I have covered at least one past MCQ also. I'm not overburdening you, but this is, I'm giving you information which is relevant for your entrance exam in whatever way the topic is asked. And what is the screening test for cystic fibrosis? The screening test for cystic fibrosis is sweat chloride test. If you find the value to be more than, equal to or more than 60 milliequivalent per liter of chloride in sweat, that is considered to be a positive screening test. And if they ask you what, there is no single diagnostic criteria, it's a set of criteria, but they ask investigation of choice, it will always be mutation or gene analysis. Mutation analysis or gene analysis. And usually 2 or more CFTR mutations are responsible for producing cystic fibrosis. Treatment requires 2 kinds of therapies. One is supportive therapy. In supportive therapy, you will give nebulization, chest physiotherapy, you will give antibiotics, plus you will use molecular agents. New agents are available, what are called as cafters. So new agents which are available are called as cafters. The first agent which was approved for use was called as ivacaftor. Ivacaftor does not target the common mutation, it targets the less common mutation called as G551D mutation. On the other hand, we have the newer agents which are now available. We have tezacaftor, we have lumacaftor, and we have elexacaftor. All the 3 agents target the common variety, that is delta F508 mutation. So they can ask you the name of the drugs and they can ask you which drug is targeting which specific mutation. So this is all that you need to know regarding the topic of cystic fibrosis. Now let us look at MCQ scenario number 9. Question will say that there is a patient who's having a underlying respiratory infection or a cardiovascular condition. Very rarely there may be a systemic patient or absolutely normal person, but there will be some degree of respiratory feature present. Cough, dyspnea, chest pain, something will be there. And the patient, when you examine the patient, there will be decreased air entry and there will be stony dull percussion note. This is a very, very useful clue. Stony dull percussion note. All the MCQs, case-based scenarios which have been asked in FMG as well as in NEET PG exam, and the case is talking about fluid collection in the chest, they use the word stony dull percussion note. Third thing, they will mention that the chest X-ray is showing blunting of the costophrenic angle and appearance of a S-shaped Ellis curve. Either of the two, if they mention, the likely diagnosis in the patient is going to be pleural effusion. Pleural effusion is also sometimes called as hydrothorax. So hydrothorax or fluid collection is called as pleural effusion. Right. So regarding pleural effusion, what are the key points that you should know? First of all, if you get an X-ray, how you are going to identify? So look at this X-ray. As you can see, on the right side, there is a significant pleural effusion happening. There is a costophrenic angle which has been lost here. And can you see the S-shaped Ellis curve? This fluid is getting collected in a curve-like manner. This is called as S-shaped curve. What is the meaning of S-shaped? Whenever fluid collects and you do a upright posterior-anterior view X-ray in the patient, you will find that the fluid column is not straight. Fluid column is always moving. If this is the medial side and this is the lateral side, lateral means to the outside. So there will always be a curve present like this. And the peak of that curve will be attained in the mid-axillary line. So axilla के बिल्कुल center में in the mid-axillary line you will have the peak happening. This is what you call as S-shaped Ellis curve. Now this is not a radiology class, so I will not go into further details beyond this. You can see your radiology notes, but just remember that S-shaped Ellis curve is a feature, radiological feature suggestive of pleural effusion. Now pleural effusion is broadly of two types, transudative and exudative. And what is the criteria which is used to distinguish between them? Yes, you know it already. It is Light's criteria. So what does Light's criteria say? Look at this table. This table very aptly summarizes what you need to know. So Light's criteria says that there are three parameters we should be using. One is ratio of pleural protein divided by serum protein. Second, we look at pleural LDH divided by serum LDH, and then we check the pleural LDH value whether it is equal less than or more than 2/3 of the upper limit of normal LDH levels. Right, normal serum LDH levels. So let us look at it carefully. If what you do is, first of all, you take out pleural fluid, pleural tap is done. फिर हम उसमें देखते हैं how much is the LDH in the pleural fluid. Then we check the serum LDH. If the pleural LDH by serum LDH value is less than 0.6, that is transudative. It is more than 0.6, it is exudative. Then we look at the pleural protein level. Pleural protein divided by serum protein. If the value is equal to or less than 0.5, that is transudate. If it is more than 0.5, it is exudate. So protein में cut off 0.5 होता है, LDH में cut off 0.6 होता है. This is the small common mistake many students do. And LDH में further देखते हैं कि pleural LDH whether it is equal to or less than 2/3 of the upper limit of normal serum LDH, or it is more than 2/3 of the upper limit of normal serum LDH. And based upon this, we classify as transudative versus exudative. What are the common causes of transudative pleural effusion? Hypoalbuminemia, like cirrhosis and nephrotic syndrome, congestive cardiac failure, and constrictive pericarditis. On the other hand, autoimmune diseases, esophageal rupture, infections like TB and empyema, malignancy, pancreatitis, post-CABG, they all will be having exudative type of pleural effusion in the patient. Right? Now, what is the therapy? Obviously, you will do the underlying management, and based upon the cause and based upon how significant the effusion is, you may or may not do removal of the effusion. Like there is a small fluid collection due to pneumonia and it is asymptomatic. We call it as parapneumonic effusion. It will not require therapy. But if there is a significant pleural effusion which is causing distress or dyspnea to the patient, the treatment will always be placing a ICDT. So intercostal drainage tube placement on the affected side will be the therapy of choice. You can do it clinically, you can do it under ultrasound guidance as well. Now, look at this question which was asked on Light's criteria in December 2020. In a patient, pleural effusion was tapped. Pleural fluid protein is 2.4 gram percent, serum protein is 6 gram percent, and LDH values as of pleural fluid and serum LDH is also given. What is the likely cause? तो कैसे चलेंगे? सबसे पहले देखते हैं what is the ratio of pleural fluid to protein. So pleural fluid protein divided by serum protein, how much is the ratio? It is 2.4 divided by 6. So it will be 0.4, right? Similarly, if you see the pleural fluid LDH level, pleural fluid LDH divided by the serum LDH, the ratio comes out to be 50 by 200. So it will be again 0.4, right? So what is it looking like? Is it transudative or it is exudative? It is transudative. And among the causes which are mentioned, congestive cardiac failure is the one which produces transudative pleural effusion. So this patient is having a transudative pleural effusion, and then you have to find which is the transudative cause of pleural effusion. If you are forgetting, you can have a look at this table also. If protein ratio between pleural and serum is equal to or less than 0.5 and LDH ratio is less than 0.6, we call it as transudative. So among transudative causes, congestive heart failure is mentioned here. CCF or CHF will be the likely cause. I hope now you will not go wrong if you get a question like this in the paper. Now, before we go further, let us do a quick recap of GINA 2023 guidelines related to asthma. If you look at the papers of FMG in January 23 and July 23, there were direct and indirect questions asking about diagnostic criteria. And if you are targeting 24 paper, January 1, as well as the later year June-July paper, this topic is going to be important. So I'm not going to go into the nitty-gritty. You all know what asthma is, how you are going to diagnose asthma according to the guideline. First of all, presence of two features is diagnostic. Suppose there is a patient, he has a family history of allergic disorders or asthma, and he comes to you with some breathing difficulty or episodes of breathlessness. How you are going to make the diagnosis? According to the GINA guidelines, what is GINA? GINA stands for Global Initiative Against Asthma, right? So GINA 2023 gave worldwide guidelines and they said two features should both be fulfilled. तो क्या लिखा है इसमें? Presence of both is diagnostic. अगर एक भी missing होगा, you cannot make the diagnosis with confidence. पहला, the first thing, there should be some symptom in the patient which is variable and reversible. Example, एक patient है, उसको episodic breathing होता है, episodic dyspnea होता है. There are certain patients who are having episodic cough. So some symptoms should be present. So what do the guidelines say? They say there should be history of variable respiratory symptom. तो patient के अंदर complaint होना चाहिए. किसका complaint होना चाहिए? Either wheezing or shortness of breath, also called as dyspnea, or chest tightness or coughing in the patient. So variable matlab sometimes it increases, sometimes decreases. Sometimes episode happens, sometimes it does not happen, right? Second cheese, her patient where you are supposing asthma should undergo spirometry. When you do spirometry, you should find variable airflow obstruction involving the expiratory part. Now I have already told you that asthma is an obstructive lung disease, right? And in patients ke andar, the problem is majorly affecting the expiratory part. And because asthma is episodic bronchoconstriction, so there will be variable expiratory airflow obstruction. तो इसका मतलब क्या हुआ? Symptom भी होना चाहिए and spirometric value भी होनी चाहिए. Now you need to remember the criteria. So the criteria says when you do spirometry, FeV1 by FVC ratio should be less than 0.8. This is something we have already done. Along with any one or more of the following. What are the other features? In asthma, there should be reversible airflow obstruction. What do you mean by reversible airflow obstruction? Suppose, see guideline आपको याद करना है. You have to remember it. But I am just trying to simplify so that you can remember it better. There is a patient. I am likely to have asthma, right? So आप क्या करोगे? First of all, you will take a baseline FEV1 value मेरे अंदर. Then you will give me bronchodilator like salbutamol, and then you will repeat the FEV1 value. अगर after bronchodilator, if after bronchodilator FEV1 increases by more than 12%, तो हम बोलेंगे this is consistent with asthma. How do you define reversibility of airflow obstruction? Is a January 2023 FMG MCQ. इसको याद कर लो. Criteria to define reversibility of airflow obstruction for asthma diagnosis was asked in January 23 question. ये पूरा statement था. इसमें percentage was more than 12%. This is what you had to identify. Remember this, right? Second feature on spirometry. Average daily diurnal variability in peak expiratory flow. Peak expiratory flow rate एक पैरामीटर होता है. इसके अंदर morning and evening variability should be more than 10%. Third, the FEV1 should increase by either more than 12% or more than 200 ml after 4 weeks of inhaled corticosteroid. तो अगर एक एंटी इन्फ्लेमेटरी एजेंट देते हैं फॉर 4 वीक्स लाइक इनहेल्ड बुडेसोनाइड, और हम चेक करते हैं कि आज सपोज आई एम अ पेशेंट टुडे एंड देन यू गिव मी इनहेल्ड कॉर्टिकोस्टेरॉइड डेली फॉर 4 वीक्स एंड 1 मंथ के बाद 4 वीक्स के बाद यू डू इट अगेन and the FEV1 increases by more than 12% or more than 200 ml absolute value, that is also consistent with asthma, because steroids क्या करते हैं? They reduce the inflammation and so FEV1 improves in the patient. Fourth thing, fourth parameter, positive exercise challenge test. So कैसे करते हैं? They are not going to ask you in the details in the FMG exam. लेकिन जब आप exercise challenge test करते हैं तो FEV1 will fall by more than 12%. Fifth parameter will be positive bronchial challenge test. जब आप methacholine देते हैं तो FEV1 reduces by equal to or more than 20%. If you are using other analogs, the values are different. But the original gold standard guideline जो use किया जाता है, drug जो use किया जाता है for bronchial challenge test, वो होता है methacholine, and if the FEV1 falls by equal to more than 20%, that is also consistent with asthma. And lastly, between the visits, if the patient is coming and variation in FEV1 is happening by more than 12%, that is also consistent. So any one out of these 6, along with FEV1 by FVC less than 0.8, along with any of these symptoms which are variable, you say patient is diagnostic. This is diagnostic of asthma. I know it is tough. End of the day, you will have to cram it up. But if you just say it out like this to yourself, to your friend, or just in front of the mirror and say 2-3 times and then solve MCQ and come back to this again, trust me, it will become easy for you, right? I'm not giving you too much of information, but this is something important, and January 23 question has been asked on this. Now, miscellaneous things. Let us talk briefly a few words about types of emphysema. What is emphysema? There is a permanent dilatation of the alveolar wall, and so the airway becomes dilated. Emphysema is considered to be a type of chronic airway disease. It is also called as COPD, so chronic obstructive pulmonary disease, right? So emphysema is broadly of multiple. See, if you look at the classification in pathology or detailed classification in medicine, there are many types of emphysema, but from exam perspective, there are broadly 2 types of emphysema. पहले देखते हैं, look at this image. Can you see these are the normal alveoli? They have a bunch of grapes-like appearance, and the alveoli are the air sacs, the alveolar sacs, and the alveoli, they are not dilated. So first variety of emphysema होता है centrilobular emphysema. Centrilobular emphysema is also called as centri-asciner emphysema. तो दोनों सेम होते हैं. इसमें क्या होता है? Terminal part of the alveoli are not affected, but the central part of these alveolar sacs and alveolar ducts, they are dilated. तो इसको कहते हैं centri-asciner. And where the entire segment is involved, that is called as panlobular emphysema, also called as pan-asciner emphysema. अब क्या हो रहा है, क्यों हो रहा है, that is something they are not going to ask. They can show you the image and ask you the reason, or they can show you what are the condition where centrilobular centri-asciner is found, what are the condition where panlobular is found. तो याद कर लो, centrilobular and centri-asciner emphysema is found in patients of COPD or smoking related emphysema, right? And if MCQ says name one common cause of pan-asciner emphysema, it is likely seen in patients with alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency, AT का मतलब होता है antitrypsin. So alpha-1 antitrypsin deficiency, it's a type of metabolic disorder and enzymatic defect where hepatic involvement and pulmonary involvement both are seen, and these patients are having pan-asigner emphysema. क्या इनके ऊपर questions हैं? Of course इनके ऊपर MCQs हैं. Where do you see panlobular? Where do you see centrilobular or centri-asigner emphysema? And so obviously you will. So let us eventually talk about few points related to COPD. Chronic obstructive pulmonary disease. There are broadly speaking two forms of COPD, although there are subforms as well. But from exam perspective, two types are there. We have the chronic bronchitis and we have emphysema. Chronic bronchitis was previously called as blue bloaters. Blue bloaters. So bronchitis was blue bloater. So BBB, ऐसे याद कर लो. Bronchitis were blue bloater. What is the meaning of blue? They will have cyanosis. They will have discoloration, bluish discoloration of the skin. Bloater means they will have edema and they will be usually obese in nature. On the other hand, emphysema is more commonly seen in chronic heavy smokers, and so they were called as pink puffers. When I say pink puffers, you must have seen a few people who are very heavy smokers, very thin, cachexic. They don't have cyanosis, they are pink, but they sometimes breathe as if they are whistling, or their lips also become like this. Actually, they are breathing through their mouth with a pursed lip breathing. So it is pink puffers used to breathe with a specific breathing called as pursed lip breathing. So they would breathe with pursed lip breathing. तो अगर edematous blue patient है COPD का, that was called as blue bloater. These were the patients who would be having chronic bronchitis. Agar patient would be very thin, pink in color, no cyanosis, but he will do pursed lip breathing and he will be severely cachexic. It's like uski body pe clothes are hanging very loosely. That person will be pink puffer, and they were categorized as emphysema. And there is a classification of COPD called as gold classification. This gold classification is based upon FEV1 measurement after bronchodilator. तो पहले आप देखते हो कि whether it is COPD or not. So FEV1 by FVC ratio should be less than 0.8. And then there are four categories: 1, 2, 3, 4, mild, moderate, severe, and very severe. FEV1 equal to or more than 80% predicted after giving bronchodilator, that is mild COPD. 50 to 79% is moderate, 30 to 49% is severe, less than 30%, or this criteria, which is not very popularly followed, is called as very severe COPD. So this is the broad classification you need to remember for the exam. Has it been asked so far? No, not yet in the recent papers, but is it important? But yes, that is why we are discussing it here. And what is the treatment of COPD? Initially, COPD patients are started on LABA. What is LABA? Long-acting beta agonist, for example, salmeterol. And if dyspnea persists despite this, you add LAMAL, that is long-acting muscarinic antagonist, for example, tiotropium bromide or ipratropium bromide. And two MCQs on these have been asked, including one case scenario in the recent exam. So you add it to your notes. If you know it already, just revise it along with me. And before I finish it off, earlier I was not well, so there was a delay in putting the rapid revision part 3 video. Part 4 video, there were other reasons. I don't want to discuss the details, but I had some technical issues happening, some unintended, some because I'm trying to teach a lot of stuff to you on a free social media platform, so there were some issues related to that. You need not go into the details, they have been handled, so don't worry. All I want to say is, with only 2 weeks to go, now nothing should be there on your mind except your focus, that is 20th January exam. I will be having 2 more sessions apart from this. One session will cover rheumatology and some miscellaneous topics, and endocrinology, miscellaneous type topics and case scenarios, and one session obviously will be neurology. So only 2 sessions are left, and trust me, I'll try my best to put them up and make them as high yielding as possible without crossing the limit of 2 hours per session, which I promised you. And the file of this session I will be sharing with you shortly. The link I will post in the comments of the video. So thank you very much, and for any doubts, any details, you can keep following me on the social media platforms, particularly Instagram. So thank you very much and all the best.